Thanks very much for the chance to talk. This is an extraordinarily stimulating, informative workshop already. Collectively, there's so much that's going on. So on behalf of myself and Diane Bunn, who's speaking a wee bit later in this session, just want to give a presentation on a completed study dealing with the impact and the lived experience of infection control measures in care homes for older people here in the UK, along with an ongoing study. The bulk of what I'm discussing will reflect the first study, but every now and then I will inject a few points for our ongoing study. Next slide, please. So at the time of the completed study, which ran last winter, and which built on some epidemiological work on the transmission of COVID-19 in Norfolk care homes earlier in 2020. A group of us did this 3 months exploratory study, and that in turn actually led to the ongoing study, which you can see from the dates, June of this year to May of next year, is much longer. So again, the research focusing on exploring what challenges and actual experiences the workforce was having in care homes during the pandemic. So the aims were identifying those experiences in terms of implementing the infection control measures and trying to get a better understanding. And I know since our last winter's study, much more work has been done on this by numerous teams, not just in the UK, but internationally. For instance, really interested to hear from Janice in Nova Scotia as well. So just a little wee bit of an add-on from for this purpose this morning and early afternoon, just to repeat that the ongoing study is a continuation, but also an amplification of our completed study, that the completed study interacted with care home staff, the workforce. Our larger study is actually talking to family and friends of care home residents and eventually to residents themselves. But our presentation is just to do with the workforce. Next slide, please. So we used mixed methods, an online survey from which we got the sort of some general overviews, general oversights, and then followed these with interviews with a range of staff from the workforce. From study one, we had 238 valid responses to the online study, and we conducted 15 interviews. I'll say a wee bit more about that a bit later. And in both the completed study and our ongoing study, we recruited nearly all the interviewees as a result of the online survey, at the end of which there was an invitation to indicate an expression of interest. That is how we did the huge majority of our recruiting to interview. And for the most part, we were able to obtain quite a wide range of the geography, occupational job roles, gender, and age. But I think, not unlike many other studies, we have been challenged in being able to interview junior care home staff. Just to let you know too, that we did involve the completed study, which was done in a very short space of time, 3 months. We did involve 2 care home workers to develop and pilot the questions for the survey. Again, because of the rush of time, we didn't have a chance to consult and liaise with care home workers for the topic guide, but we have definitely done that and are doing that for our second study. And I think I'm allowed to say that as of today, my colleague Diane Bunn has led our publication, and it is now actually published. I'm not sure if Diane, if this isn't cheeky, if you want to put that into the chat. Next slide, please. This is hugely brief overview just to give a smattering of some of the context. And I've included this slide because there was that psychological breakthrough within the UK in January last year, reaching 100,000 deaths for the first time. Next slide, please. And the next slide isn't a complete one-to-one correspondence, but official government figures are that the number of deaths in the UK had gone up to around 145,000. I know there's a wee bit of controversy as to whether that should be, how that should be measured, but just to give you an indication. Next slide, please. Sorry, that was really, really brief, just to give some sense of the context. So from the completed study, we had 238 valid responses, and you can see there the range of ages, predominantly female. And the qualitative interviews we did, conducted 15 last winter. In the ongoing study, we do have slightly more variety amongst the interviews we've managed to do to date. But again, we've had very, very low uptake in interviews from junior care home staff. For instance, on the current study, only one person has come forward in the age band from 26 to 35. There's no one younger than 25 and younger amongst the interviewees. So the bulk of the age groups are in the age band from 36 to 45 and above. And then just the survey data, how they were analyzed descriptively, and the qualitative data analyzed thematically. The next slide, please. So the sample of the workforce with whom we interacted was very motivated to provide care to the best of their ability, to the best of their capacity. And I want to take this opportunity right here to salute them again. And I'm sure we're not unique in this in the studies that Diane and I are conducting, that we're so touched as well as impressed by the sacrifices and the dedication of the workforce. And multiple challenges, though, were faced by the workforce, which again have been referred to from many, many different contexts so far this morning, such as PPE, such as the nature of the guidance, and also how were they being supported given the highly distressing circumstances that they were facing. Next slide, please. So to start on the more positive side, what did enable the staff to deal with infection control measures and to carry out their work? Very important factor was that sense of collegiality, the team spirit, as well as trust, as that quote from the first participant indicates, that if you trusted your colleagues, it did help to deal with situations, no matter how upsetting they were. We had examples of very effective carrying out delivery of communication within the care home that tended to build on what was already in existence prior to the pandemic. It's not that some care homes didn't rise to that effective strategy of communication once the pandemic started, but the odds were, based on our data, that if there was already a good communication flow within a care home, it was much more likely to continue. And that meant that the same message was being filtrated out to everybody, whatever their job role was within the care home. We did find that in the first study, that is the completed study, that no one reported PPE shortages. And here's an example of, I'd just like to inject a contrast to. Based on the interviews we've conducted so far in the ongoing study, we've had 2 occasions when staff have reported that was quite serious, that they did encounter PPE shortages, which were incredibly distressing to try and deal with, and having to resort using bin bags, etc. And again, remember the different timelines. The completed study took place last winter. The one that's ongoing started this summer. Next slide, please. Just a snapshot of examples about the morale and attitudes from the online survey in study 1. In general, there was quite a high degree of feeling upbeat despite the challenges, and that tended to reflect that sense of collegiality, working well together. You might also be interested that from that survey in the completed study, huge majority had no desire to want to find work in a different care home. And also there was a very high positive response about the support that they obtained from their manager. And emotionally, perhaps some people might find this surprising because of course there's a lot of evidence to the contrary, but based on the completed studies survey, there was actually quite a strong response on the positive side, finding work rewarding. We're not yet in a position, by the way, to report on findings from the survey in the ongoing study. Next slide, please. There were, of course, a lot of barriers, which won't surprise anyone here. Not in any particular order, but of course they start with that sense, or understandably, perhaps they start with that sense of lack of preparation, including an awareness of what it means to prepare for highly infectious disease outbreaks. Of course, that included the outbreak of COVID. Training was reported as being very, very inconsistent. Sometimes staff members were left to their own devices. Sometimes the method of training wasn't appropriate or not inclusive enough, because as you know, all of us have different ways in which we prefer to learn. There was a lot of difficulty when staff were asked to wear more PPE all the time, and actually when caring, delivering their personal frontline care, huge barriers. This included, wasn't limited to making effective communication with the resident. It also included things such as rashes and reactions to wearing masks, continual hand washing. Though from the second study, we've been hearing that there are some staff who are reporting very little reaction or rashes to wearing PPE. Hydration issue came up quite a lot. And that sense of, am I safe, am I not safe, is encapsulated in that quote. If you don't know whether someone has COVID, you might have this be lulled into a false sense of security. The sense of fatalism also came up in the completed study, that, what's the point for a few staff, or I'm going to wear my PPE, I'm going to do what I can, but whether or not that's actually going to help me, help my chances of being catching COVID, whether that'll reduce them, I just don't know. Next slide, please. A lot of data reflects the lack of personal support, professional support, and social support when faced with very, very emotionally upsetting situations. That added a lot of burden to the staff, using words like that it was daunting, feelings of despair. One of our interviewees said that I have to keep going because if I stop and to think about it, I might actually collapse, I might actually crash. So just keeping going, going. And other things that added to their distress was that care home staff, and I know this has been reported in many other places, that they felt they were forgotten compared with their colleagues in the NHS, that they were we're second-class citizens, we're the forgotten people. And I alluded to this before, but the problems, the barriers presented by advice and guidance that seem to be relentlessly inconsistent, confusing, ever-changing. And you can understand why participant D said, why isn't everybody singing from the same hymn sheet? Everyone should be adhering to the same standards. And this could lead actually not only to frustration, but to self-doubt. Next slide, please. There were problems, of course, in caring for residents living with dementia, especially, but not exclusively, in the earlier stages of the pandemic. Residents who live with dementia not understanding, being highly distressed by care home staff wearing full PPE, the difficulty of wearing a face mask and making one's facial expressions fully known. And yet it's also incredibly difficult, as this participant reported. How can you isolate somebody who is living with dementia? And not unlike a comment I made just on the previous slide, there did seem to come across a very strong feeling that the basic stuff in infection control, it's the most important, but that also should be the norm, as participant F is saying, that should be the norm for everybody. Next slide, please. So we found that care home staff were drawing upon infection control and prevention measures to do what they could do to the best of their ability to protect their residents as well as their colleagues. And we have many examples to say that staff going beyond the extra mile is an understatement. But also many factors did have an impact on how infection control measures were taken up, the efficacy of those measures. It might, in fact, this point came up in the presentations just before our break, it might have reflect the layout of a care home. This was especially true for older buildings that were very, very hard to renovate or alter. And I know, as I said, that has been reported elsewhere. Levels of anxiety. We had staff saying something along on the lines of, you feel overwhelmed because you're not able to do the job you're supposed to be doing because of all the changes that are going on. And I think this last point is very important. It did come up from a variety of staff that people on the ground were not consulted, whether it's by different levels of government, organizations such as the Care Quality Commission, the CQC. Why aren't they asking the people like us on the ground? Because many of those people who are devising these guidance, they either don't know about care homes, or it's been so long since they were directly exposed to care homes, they're out of touch. Next slide, please. Our findings are increasing and adding to the collective, and I don't only mean Diane's and my studies, collectively, all of us here, our understandings of what it means to work with, handle, and make the most out of infection control measures to limit the spread of COVID-19. And it's so important to understand and learn from the workforce how best to support them. And the extent to which the workforce was prepared and is prepared to dedicate, if not sacrifice themselves for their residents and their residents' welfare, I think that can't be sung out too many times. And if I have time to give one example, in our ongoing study, a member of care home staff talked about the fact that earlier this year, 2021, very, very resident person-centered focus in her team, and they all agreed that they were going to pack a bag, leave it in their car. So if one day when they were at work, they had to stay, whether it was one day or for an extended time in their care home, they were ready to do that. And their inclusive approach also was revealed in the fact that the care home management recognized that for a few members of staff, this wouldn't be possible, perhaps because of childcare or other issues. And so they made the point to those few other members of staff, but you will be so important if we are literally locked in with our staff. You can help, you can bring deliveries to us. So I find it quite inspiring, many of these examples, but we do need explicitly to include the experience and voice of people on the ground. And just the next slide, I just want to acknowledge that we really thank not only our participants, but the care home staff and our PPI carers on our ongoing study for really guiding us, improving us, and our instruments that we're using. Also want to acknowledge our funders. And the next slide, please, is just to say, you will get a copy of these slides, but I just want to acknowledge the credit for that. And then the last slide is just to give you an indication. The bulk of us from the two studies are based at the University of East Anglia, UEA, but we also have colleagues beyond, including from Newcastle, Care UK, and a PPI carer. Thank you very much.
Thank you very much, Kathleen.